Hang on one
Mary, too late. You got the floor.
second. Good evening. Thank you, everybody, for joining us. My name is Meredith Rothstein. I'm a survivorship specialist with the Delaware Breast Cancer Coalition. Just a housekeeping item. If you have questions for Dr. Newell as we go through the process, if you wouldn't mind either keeping a note of them with you or putting it in the chat, Connie Holdridge, the Director of Survivorship, will be monitoring the chat as we go through tonight. And any other questions, you can message her directly. But good evening and thank you for joining us. I have the distinct pleasure of introducing you. Many of you already know her, Dr. Wendy Newell. She is a has been a general surgeon in Dover, Delaware for the past 30 years. She was the chief resident from 93 to 94. And her general surgery residency was at Geisinger Medical Center, and she graduated from the University of Pittsburgh School of Medicine. She is my breast surgeon, so I'm so excited to be here with her. And most importantly, it's not very well known yet, but today it will become that Dr. Newell is a recent breast cancer survivor. And so she's going to share a little bit of how she came to this point in her life and how it's changed. And we have some questions, and I'm sure you all will have some questions as well. Take it away.
Well, thank you. Thanks for inviting me. And Meredith is she's definitely a fan, and she does know that I had breast cancer, and it is sometimes kind of hard to share as a provider, or how much do we share or not. So they asked me to do it, and I think I'm far enough along where I could say yes, and I'm willing to share my story or say the words I had breast cancer. And so then they said we could pre-record like you talking about yourself for 45 minutes, which didn't seem very nice. So I thought what I'd do is spend a little bit of time, maybe just about how I became a surgeon, or how I kind of got into all this before I got into what's happened recently. So many don't know, but when I was a child, I actually had a lot of surgeries myself, a lot of orthopedic surgery. And what I think that did, it made me interact a lot with physicians. It made me very comfortable in hospitals. What I remember, though, is a lot of that post-op pain as a child. But somewhere along the way, I started admiring the doctors taking care of me. And probably in junior high, started saying, I'm going to be a doctor. This is what I'm going to do. And you could literally, and I tell my kids that, or other people's kids that, is you can say, this is what I'm going to be, and just put your faith in the system and work hard. And so I went to Syracuse University, and then I got into University of Pittsburgh School of Medicine, just saying, I'm going to be a doctor. And by the time I was applying to medical school, I thought, I want to be a pediatrician. Like, I really loved kids, and that's what I was going to do. But it turned out when you rotate through peds, kids scream and don't like their doctors, and the parents aren't very friendly either. And it wasn't out in the community, it was at a hospital setting, which probably changed it. But the surgeons in medical school loved what they did. And they literally, we ran to traumas, and it was just exciting. And they just fix people. They fix people kind of right away. And patients are kind of very grateful at what you do. And so by the end of my third year, I'm like, that is what I'm going to do. And when I applied for residency, less than 13% of all surgeons were female. And so there was probably a rare chance that I could match. And that's what happens. You kind of, everybody applies and interviews. And I matched at a very small hospital in Pennsylvania. I wanted to be at a big trauma center, but I always say the Lord puts you where you're supposed to be. And I had really good training, very broad. And I thought, I'm going to go out and be a community surgeon. I like the idea of doing everything, being this general surgeon. And when I interviewed places, Dover, Delaware is the biggest city that I looked at. And I interviewed with two older surgeons, and they got called away to do a gallbladder. So I went in and watched them work together. And I could envision myself in this town, kind of near the beach. I grew up outside Philadelphia, and this is where I wanted to be. This is where I thought I could be and practice. And I feel like Dr. Hamilton, Dr. Inge, if people know him from years back, but I really feel like when you go out and practice, having mentors that really set me up, I feel like it gave me such a good start to be in practice here in Dover, and be very passionate and overall general surgeon. And then what happened after a few years, the lady that would eventually become my mother-in-law got breast cancer. And then my sister-in-law, when she was early 40s, got breast cancer. And then my mom got breast cancer. And then my stepmother got breast cancer. And not that I operate on my mother, but I felt so differently kind of being on that family side of things. And I had to stay educated. I wanted to be the one with the knowledge. And Bay Health was kind of starting up into their cancer institute. They sent a medical oncologist, a radiation oncologist, and myself down to Emory University. And we all got a special certificate in breast oncology. And it just became more and more what I was passionate about. Went to a very early organization, the American Society of Breast Surgeons, where there were only a couple hundred of us in a room, trying to make sure we're all staying cutting edge. What should we be doing? What is next on the horizon? And these organization has grown into thousands now of breast surgeons. So my passion led me there. And then probably about now a little more than 18 months ago, I'd had a normal mammogram in February, but in July, as a high risk woman, I was also getting breast MRIs, and I had to have biopsies because for a suspicious area. And using urine, I could get in and get biopsied right away. And I was going to talk about who told me I had breast cancer, but I had ordered my own biopsies. And the pathologist called me and he said, "Are you kidding me? Is there no doctor on this?" And my GYN doctor was out of the country. And I said, "You have just got to tell me." And he couldn't say those words. I said, "How about you tell me my receptors? What type do I have?" So he did that. And I was actually on my way to a colonoscopy. So I kind of might have told my family I don't know those results. No, that pathologist didn't call me. But when you're a little doped up, one of my kids was like, "Yeah, just look on her my chart." I was like, "Yeah, look on my chart." Oh, then they all knew. So my husband knew and my daughter knew. And we were headed to dinner with his family and they knew. And like all of you, had to find a surgeon, had to get care. And I all of a sudden was on the other side of this place that I didn't want to be. And the fear. So I tell everyone it's such a curable cancer. Biggest group of cancer survivors in the US had breast cancer. That's what all this pink ribbon stuff is about. We're going to cure you. So I know all that stuff, but when it's you, it doesn't matter. It was fear. I don't like to say shame, but I couldn't say those words. I couldn't tell people. And so I had my surgery and then I had radiation, and now I'm going to take a pill for 5 or 10 years. And I really just kind of tried to pretend I didn't have it. I tried to minimize it, and then I kind of regretted it. Like I didn't feel like I wish I kind of wanted to be babied more through it, but I did it myself, kind of minimizing it, and you are okay. And it is just a little fatigue with radiation or burning. And so it really changed how I spoke to patients. I think with my family going through it, it changed how I was with patients. But I feel differently now telling a woman, looking at their family and telling them, and I try and hold them if they want to be touched. feel like hopefully I can absorb some of their fears and calm them and let them know it's going to be okay, and get them through the process of everything we have to go through before you get to that surgical point, and help them move on. So
I have some questions for you. What do you love about your job?
I still love fixing people. I love, um, especially with breast cancer, because now I've literally eliminated most general surgery. I mainly do breast, some thyroid. So you want to be cutting edge. You want to be the one that knows what to do. So staying up to date, going to these classes and learning the best surgical techniques, but also, medically, the best way we're going to treat and handle this in a multidisciplinary fashion. But telling them they're going to be okay, and then they come back and I mean, some of them are like, you saved my life. And to me, it's, well, if you're shot or stabbed and I really save your life, like, that's one thing, but I know they feel that way. I just, and how can it not make you feel good to do
Absolutely.
that?
What are some things that frustrate you about your job?
Mhm.
If you can say.
There really isn't a lot. I wish there were more hours in the day. And I think when I got diagnosed, people are like, so now you're going to take the trip, you're going to go away a lot. And I looked at my husband, I said, no, I never want to not be here for every patient. Like it hurt to cancel and move patients for my own surgery. And, or when I go away, and people are understanding, but to not be there that week that they wanted their surgery, or they need their talk, or, so that's frustrating to not be there for them sometimes.
So, what is one thing that you wish all breast surgeons understood now that you've been a patient of a breast surgeon? What do you think they need to remember or take into consideration as they treat their patients?
I think some patients want to lead their surgical decisions, but others, they want you to make it. They're like, I'm not the expert. Like you understand the nuances, lead me to the answer I should have. And I think certainly when I was a younger surgeon, I was like, you can do this, you can do that. Yeah, what would you like to do? Oh, we would never do that with colon. We don't say you have a right colon cancer. Do you want me to take your whole colon out or just the right side? But it's never been like that for breast. You can have a lumpectomy, you can have a mastectomy. And for a while, the US is the only place where double mastectomy is on the rise. Everywhere else in the world, it's on the decline. So even with more and more genetics that might push us to recommend bilateral mastectomy, it shouldn't be so hard to say, I think you should have a lumpectomy. I think you should have a lumpectomy and sentinel node. And if you need more, we would recommend something more. Does that commit them to radiation many times? Maybe not in older women anymore. So it still can be their choice, but I think I feel like I should lead more in that decision and say, this is what you need.
And so, you touched a little bit on it. How has becoming a survivor changed your perspective on the work that you do every day? And I can say, as one of your patients, you are very relatable. We talked a little bit about doctors and the relatable doctors and the not so relatable doctors. And I feel that you're very relatable. Is that something, a conscious decision you make, or?
Nah, well, I think you evolve. So I think as a young surgeon, you're probably more uptight, more like things have to be this way and more regimented. And the longer I was a surgeon, I feel like the more relaxed. Like it doesn't have to be, you can be more relaxed. And breast patients tend to be huggers. So no matter where
Walked in and hugged her.
no, I would say whether you've been operated or not, sometimes it just gives them confidence. But I feel like I am a toucher, so even if I know they're not going to want to hug, like sometimes I put my hand on the table or on their arm or on their leg, and I feel like I try to tell them, I'm going to take good care of you. Like at the end of when I walk out of the room after first telling them they have breast cancer, you're going to be okay, and I'm going to take good care of you. And some have very advanced disease, but they still want to know someone's there for them. Even if I know they can't have surgery, I'm going to organize your care. I'm going to get you where you need to be to these specialists that are going to be the next step.
That's fantastic. Well, for those of you who know me, and some of you do, some of you do not, one of my passions is clinical trials and research, because I feel, well, it's very evident that a lot of the advances that have been made come from clinical trials, from doing research, from figuring out what works, what doesn't work. And Dr. Newell has a new clinical trial that she is getting ready to start here in her practice. And it's very exciting. And so if you wouldn't mind sharing about it, and
Sure.
because I think it's a great opportunity for us as survivors. And obviously with clinical trials, you have to qualify. But the company, Natera, which I think we've had them doing in the loop with us before.
Okay.
So some people may be familiar with them. They did my genetic testing, but you're working with them to accomplish this. But
Yes.
I'll let you share
Okay.
the whole
So,
soup to nuts.
Sure.
Okay.
Well, I would almost start at University of Pittsburgh, and I was telling her, there was the surgeon that kind of created the clinical trials for breast cancer care. The NSABP trials were multi-institutional trial where a surgeon thought this is not necessarily a localized disease where you had to have that radical Halsted mastectomy. He thought it was more of a systemic disease. Think about cancer cells kind of traveling through. And he thought if we could kind of figure that part out, killing those cells with chemo or using tamoxifen, that you could have less surgery. So those first trials were women that took that leap of faith to maybe just have a lumpectomy instead of mastectomy. And that was not standard of care. And so I think having medical school at Pittsburgh really sets you up for believing in clinical trials and how it literally changed the world for breast cancer care. And then I shared a little bit at Geisinger. We were part of the STAR trial, which for anybody that has family, high risk women could be on prevention medicine. And back then, 30 some years ago, 35 years ago, tamoxifen was given to high risk women to cut their chance of getting breast cancer by about 50% or more. So not for treatment, which was given to cancer patients, but for prevention. And then the sister drug, raloxifene, what if it could do it with less or different side effects? Raloxifene was given to postmenopausal women to improve their bone health. So many older women had osteopenia or osteoporosis. We could give them raloxifene as a preventive agent. So the STAR trial, and when I moved down here, found places, and I was still enrolling women on the STAR trial, tamoxifen versus raloxifene, and they had almost equal breast cancer prevention out like 20 years. There was a little separation where maybe tamoxifen was better. And now for prevention, both those drugs are available, and also the 3 aromatase inhibitors. So that in itself, I'm very passionate about a high risk program. Since I came to Delaware, and my PA and I run a high risk program for families that have family history of breast or ovarian. Little sidetrack.
Yeah.
So at my last meeting, I really wanted to learn about the circulating tumor cells in our bloodstream. And Natera does a tumor specific blood test, ctDNA, you'll hear it referred to, or people call it a liquid blood test. And it's been around being used for colon cancer and now being used to help detect breast cancer. And what our clinical trial is going to look at is women being diagnosed at stage 2 or 3 before they get any treatment. Can we pick up their tumor in their bloodstream? And so what Natera, the company, does is they get the tumor block from your biopsy or your surgery, and they're going to analyze its DNA, and then from a blood sample, see if they can find any of that DNA in your bloodstream. And then every 3 or 6 months, we're going to check your bloodstream to see if we pick it up. because right now, and many of you probably had stage 2 or 3, and I was a 2. And what do? We just hope that the treatment we had worked. You
Mhm.
know, surgery, or you had chemo, did you have radiation, are you taking your pill for 5 or 10 years? And yeah, just faith. And the imaging is usually local imaging. And if you've had a bilateral mastectomy, we're not even doing that. So, what if instead of looking for symptoms of distant disease or pain or lump for a local recurrence, what if we were checking your bloodstream? And so before you get a metastatic focus, a lesion in your back or a spot on your lungs, we could pick it up, and then it might trigger advanced imaging. And maybe not yet, but I have to think it'll eventually trigger earlier treatment so it doesn't become stage 4. And
It's very exciting.
so it's very exciting. And what do we do if, you don't qualify for the clinical trial, right? I'm ordering it on stage 2 and 3 patients. I'm ordering it on people that had very aggressive stage 1 cancers. Natera is a very patient-friendly company where they're going to bill your insurance, but if they say it's experimental or whatever, they aren't going to pay. They are not billing the patient. So when patients come back and they're like, now I just live in fear. Me too. Me too. So I talk to them about it. I have an educational handout I give them about Signatera. That's Natera's ctDNA test. And if they're willing, we order it. And I haven't had any positives yet, but I've only ordered about 10. Mine's negative. It came back yesterday. And so, yeah, I think sometimes surgeons are leading the charge in a non-surgical way, but getting this information, like we did with Oncotype, which is studying the DNA of an invasive cancer to see if chemo would work or not. And we had to lead the charge because oncologists, they couldn't believe some of these patients didn't need chemo.
Well, this is super exciting because I'm sure, as you know, Delaware is #1 in the country for triple negative breast cancer, as well as #1 in the country for triple negative breast cancer in women of color. And having access to a test like this and not having insurance or funding be a barrier to them getting access, this is a huge deal. And I think too, because there are so few treatments for triple negative, being able to find it sooner to prevent it from going to stage 3 to stage 4,
Yes.
could extend a lot of lives. Do people need to be your patient to participate in the trial, or can their oncologists or surgeons reach out to
So
you?
it's going to be a combination with Bay Health.
Okay.
And so to get in the clinical trial, we're going to order it before you have any treatment. So some stage 2 or stage 3s need neoadjuvant treatment, chemo first, and some are going to get surgery first. So we're going to have them draw your blood before that. And then go from there. Is it in your bloodstream before you get any treatment? And then once you've completed either your chemo or your surgery, then keep checking, set you on one of those 3 to 6 months.
Gotcha.
Some oncologists are like, check it and we'll use it. But I think there are a lot of hesitant medical oncologists. What does this mean? Why are surgeons ordering it? But maybe you just have to be a surgeon that had breast cancer. Right. I'm
It awakens.
in that worry group still.
Yeah.
Right. I did everything I was supposed to do. Now, just looking for sign or symptom of a recurrence doesn't quite feel right if I could pick it up early.
So just from my clarification, and maybe some people out there are curious, in doing this test, this is definitely different from, occasionally Dr. Sani will pull tumor markers.
Yes.
So it's definitely different, but
So it's tumor specific. So
Okay.
it's looking for your cancer in your bloodstream.
Gotcha.
So different when we're doing tumor markers, which they don't do a lot except with more advanced cancers. But yeah, so some of these tumor markers might go up. There might be other reasons they went up. We found ovarian sometimes when their breast tumor marker went up.
Interesting.
But yeah, this
Scary.
is a totally different, a blood test looking for your breast cancer in your bloodstream.
Well, if anybody would like to get in touch with Dr. Newell in regards to this clinical trial, I will send an email send an email out in the morning with how to contact her office to get in touch
And
with her.
so for the clinical trial, not open yet, Bay House, you know, they go through consent, they're trying to figure out the statistics, how many do we enroll and all that. And is only going to enroll people that haven't had their surgery or treatment yet. But I'm gonna run it on patients that are stage 2 and 3.
Wonderful.
So
We do have a question
Okay.
to that point, to your stage 2, stage 3. You're going to run this test before they get treatment so that the pathologist can look for, or Novartis can look for the tumor-specific DNA. All right. So does that mean that going forward, if you run this test on somebody that does not have breast cancer or doesn't know that they have breast cancer, that this test, assuming your trial goes the way you want it to, okay, and we say this is good, so then it goes out to the general public, and we're trying to come in to find people that have breast cancer. Will this test be able to pick up breast cancer if you don't know you have a tumor?
So not this one. This
Okay.
one is your tumor specific.
Okay.
So if you've had breast cancer, the company's going to get the breast cancer from your lab. It can be years back. Analyze the DNA of your cancer and look for your cancer in your bloodstream.
Okay. So is this a precursor to another direction to come up with another way to diagnose breast cancer by the blood eventually?
I think eventually it will lead to that, and
Okay.
and there are probably a lot of other pathways being investigated. MD Anderson really leading the way in some of this research. So that's kind of a different pathway. This is very tumor specific per patient.
Okay. So it is to tell that the treatment worked. That's what you're going for.
Well, I don't know if it'll tell you your treatment worked, I guess. Like, so we all go through this treatment that we needed, and then and patients are still asking me, am I cured? Am I cured yet?
Right.
So we don't know that you have any cancer left. And so then we're all following you for local recurrence. We follow you for, are you developing a sign or symptom of distant disease where your breast cancer might have gone to your bones or your lungs or somewhere else? But what if we were doing a blood test that might pick it up before it became a mass in your lung? And so potentially, to me, eventually driving treatment before you develop stage 4 disease.
Okay. So Lois is asking, so can I do this being a 24-year survivor?
So all we would do is I'd order the test, and then the Signatera test, and Natera would try and get your tumor from where you had your surgery or your initial biopsy.
So yes, Lois, assuming they can get the information they need.
Yeah, thank you.
And many places kept these tumors. So it's not a fresh cancer but many places still have the cancers there where they can send out the slide to get analyzed.
Nice.
Does anybody have any questions they would like to ask Dr. Newell? You're welcome to turn on your camera and unmute if you would like to ask her directly.
Would you like me to stop the recording before people turn the cameras on?
Yes, please.
All right, I'm going to stop the recording.